Glade Bender, and I'm also one of the pediatric oncologists at Columbia University. Like Alice, I had the pleasure of treating Hank in our neonatal intensive care unit 8 years ago. Anybody who knows me knows that I don't like to walk into the neonatal intensive care unit, and I really don't like to treat babies with chemotherapy. In fact, one of my colleagues, Daryl Yamashiro, said to me when we first met Hank, are you ready for this? And I had to think about it. But it turned out that, for example, Freddie and I had a lot of similarities. We had used the same obstetrician. It just had to be. So I gritted my teeth and I did it. And what's amazing today is that you thought this crate was for Hank, but this crate was for me, because that former NICU baby is now, at the age of 8 years old, taller than I am. And that's pretty amazing. So as a pediatric oncologist, we're pretty proud of ourselves. Overall, we're curing 4 out of 5 children with cancer. That's 80%. That's a pretty good number, but it's not good enough. Whereas I had the pleasure of treating Hank, the majority of my patients actually reside in that 20% of patients who right now our therapies are failing. And so I spend a lot of time with patients who have been told that there's no hope, that there's no other option. And I try to find something new that will help them today and maybe help everybody, any other child that's affected with cancer in the future. We do this not only through the Children's Oncology Group clinical trials, but through another sort of subset of our clinical trials, of which Alice has helped me from the onset, and we call this our Developmental Therapeutics Program. Our Developmental Therapeutics Program, the cornerstone is the Children's Oncology Group. It's funded by the National Cancer Institute. We are one of 21 centers in the country who are allowed to do trials of new agents in children. And so this is something that has been growing over the years. It's now become really certainly a tri-state area known program. And so we see the worst of the worst cancers from all over New York, New Jersey, and Connecticut. What we try to do is marry patients to clinical trials, which may not cure them today, but hopefully will give them at least a longer life with good quality. And sometimes, actually, amazing things do happen. For example, I currently take care of a 17-year-old, a 29-year-old woman. She was 17 when I first met her, and at that point I knew she had a disease for which there was no cure. So we started to put her on these kinds of clinical trials, and we were ahead of the curve, and we found that a new class of agents actually works for her tumor. And so 2 weeks, she will be turning 29, and in a few months she will be getting married. And this is why I do what I do. And what we do, we're trying to do even better. So I think many of you have heard of the terms precision medicine and personalized medicine. And I used to take offense of the word personalized medicine because I thought everybody should have personalized medicine. Personalized medicine just means having a good doctor, I think. But that's not all that common. So let me start with precision medicine. Precision medicine is really about figuring out what makes the tumor tick, and then seeing if you can find a drug that can shut down that clock. And that's what we've been doing now for the last 2.5 years, when we were joined by Dr. Andrew Kung, who's here today. And that was really his brainchild, was to bring the technology of tomorrow to Columbia University today. And what we've been doing is sequencing to the letter the genetics of any individual patient's tumor. We also sequence the patient and figure out what is the difference, what makes that tumor tick, what makes it grow out of proportion to the rest of the child. And then if we can figure that out, then maybe we have a drug that can shut it down. And so we marry the precision program, which we call PIP-Seek, which I like because you can mix it up with Pip-Squeak. And we do have little patients, but we even have a Pip-Squeak program, which means we can also model individual patients' tumors in a mouse. That is our Pip-Squeak program. So we have Pip-Seek and we have Pip-Squeak, and then we have developmental therapeutics. And we hope that with our sequencing, we can marry for any individual patient the tumor to the drug that might help them. And this is really something very unique because there are a lot of programs out there doing different kinds of sequencing. It's less comprehensive than the kind of sequencing we're doing, and then they don't have access to the drugs that we need. And so here at Columbia, we have both. We have the most comprehensive, newest technology, and we have the developmental therapeutics program to get kids access to drugs. We've just been able, over the past couple of months, to deliver this message to another foundation in New York City. And they have just granted Dr. Kung and our program $1.5 million so that we can extend this program to any child who is in the 5 boroughs of New York with a high-risk cancer, regardless of their ability to pay. And the idea here is that this may drive more patients to Columbia. We'll get the drugs to the patients and the patients to the right drug. None of this could be possible without Hope and Heroes. Grants that, like this one, fund the technology. But as Alice Lee alluded to, the personalized part of this is human resources. And it's very hard to fund human resources. We need research staff to convince the FDA that we're allowed to give these drugs to children. This takes hours of time for one patient, completely unfunded mandate, to try to get a drug to a patient. We need the data to report back to the FDA so that if it works, we can do it for somebody else. And these people are not paid for by the hospital. They're not paid for by the university. They're paid for by you. So thank you all so very much for joining us today, for allowing us to deliver personalized precision medicine so we can cure more children tomorrow. Thank you.